right, and welcome back to the next 40 Under 40 Public Health Catalyst Award podcast show. I'm your host, Dr. Candace Carpenter, the Chief Executive Officer and Chief Strategy Officer for the Boston Congress of Public Health. And we have a new voice with us today, Dr. Avik Ray. I'm not going to spoil your introduction, so go ahead and introduce yourself to the audience.
Thank you, Candace. Hi, everyone. My name is Dr. Avik. I am right now a postdoctoral research fellow at Brigham and Women's Hospital, Harvard Medical School, doing a lot of real-world evidence data analysis in medicines and vaccines. But before that, I completed my medical school from India, did my residency as well during the COVID years. Then I got deeply interested in data science in the healthcare space. I jumped onto the field of epi, did a master's from the School of Public Health, and then, yeah, I've always been curious about new things in the healthcare space, and always wanted to combine. When I was a kid, I wanted to be an engineer, honestly. So that kind of inclination towards data and something to do with maths, computer science, that was always there. And I think this is a perfect time for people who are interested in health, data, and like expanding their knowledge in that intersection. It's a perfect time to be with everything going around. And so that's briefly about me, and mostly about the professional part of it. On the personal side, I used to be a part of a band, a musical band back in India. I'm really interested in music as well. So I'm a singer-songwriter, write my own songs, play with my guitar whenever I get time. So yeah, that's briefly about me.
Yeah, wow. So many different directions we can go. And so like a few things I want to tease out of just your introduction. So you mentioned like in your background, doing a residency specifically as in pharmacoepidemiology.
Yeah, so it was mostly in clinical pharmacology. So it was like 40% was in medicine and patient care, which was almost like a general practitioner, what they do like day-to-day stuff in the outpatient department. And 60% was being part of phase 1 clinical trial, phase 0 clinical trial, giving those microdosing to patients and see the pharmacokinetics, pharmacodynamics. So it was a very interesting residency, and I got an opportunity to mix pharmacology with medicine. But that being said, half of my residency was in COVID. So when I was in my second year, so second year till the end of the third year, it was between 2020 and 21. So I mostly learned about pulmonology and infectious disease rather than exploring other stuff in my second and third year. But that was also great because that gave me an opportunity to be a part of a big clinical trial, which was organized by WHO at that point between remdesivir and interferon, and also hydroxychloroquine for a month, and then it went away after we got bad results. So yeah, I mean, I didn't expect to get involved with an organization like WHO so early in my life, but it was a great experience as well, and that kind of steered me towards data science in a way.
Absolutely, absolutely, and for the audience and for myself, who's not as familiar with pharmacoepidemiology or that particular type of residency, what can people expect? So I know you said that COVID kind of changed what you were exposed to, but if COVID hadn't happened, what are some of the things in general that people can really come to understand in that field?
Yeah, sure. So it's very common in India and in UK as well to combine your kind of residency with something in basic science like pharma or microbiome or biochem. So I chose pharma because I wanted to understand more about medicines. So in terms of career options, what usually people do out of that is to join the pharma industry as a medical advisor or medical affairs, clinical development as an associate medical director. But I got more interested in understanding more about epi and biostats. So instead of joining an industry right away, or so many people do join industry and part-time, they also act as a physician in their own clinic. So that's a very common traditional route. But I wanted to come to the US and explore the entire data science space that was going on at that point, because when I was reading papers, I was just reading papers from a clinician perspective. But the section in the paper that used to always interest me the most was the method section. So I was like, what's happening here? I have to really get to the crux of it, just not read the conclusion and the abstract and get done with it as a clinician. So that kind of also, as I said, I was a part of a clinical trial, and that gave me an opportunity to actually analyze data, a big Excel sheet, actually doing stuff and not just putting clinical inputs with the data science team. So I got to wear different hats at that point of time in those 3 years. So that kind of inspired me not to join industry directly or just practice with patients, treat patients, but do something different, which usually people don't do. From a, it's very unconventional. It's non-traditional route, especially as an Indian doctor. Many people do here, I know, but it's very unconventional back home. And it's a good thing, I guess, because many people since then have reached out. From Indian MBBS like students, which are like bachelors in medicine and surgery students, they've reached out asking like, how can we do the things that you are doing? So is there a path? And so it's kind of inspiring to hear that people are more and more people are thinking of just combining their healthcare background with data science interest.
Yeah, absolutely. And so like just bring me to the question like when you did your master's in public health at Harvard Chan, and you mentioned like that it's one of the best times to have that intersection of like data science and health. So tell me more about like your time doing the master's in public health and how that's really transformed your career.
Yeah, so it was more of a Master of Science in Epi. So it was less of like, the public health courses, which is the leadership courses. I wish I had taken more right now because it makes sense. But it was very technical, like going to the crux of causal inference, thinking about new biostatistical models, regression analysis, and of course, like machine learning and deep learning as well. So it was very technical. And sometimes I used to just take courses, which talked about health systems just to get rid of the scientific rigor of the class. So it's very technical, but that's what I was looking for, to learn more about the quantitative methods. So when I came here, I thought I would be like the worst student of the class, but then I realized like the professors are really, really helpful. And you learn so much from your peers who come from various backgrounds and public health. And I think that's a beauty of public health. Like you have journalists, you have lawyers, you have like, people who have done bachelors in neuroscience, somebody who is in med school here doing an MD, somebody who is like coming back after 20 years of practice, want to learn now, epi and biostat. So it's really inspiring. And I learned a lot from my peers, I should say. And so I graduated last year in May, and it was a great 2 years of learning. And that kind of motivated me to stay on the academic side of things, join Brigham as a postdoctoral fellow, and carry on, my interest in this data science space, because right now, like some of the projects I'm involved in at Brigham, it's like really, really interesting and something I would have never thought I would be a part of, even like a couple of years back. Sometimes I'm like, okay, I'm doing like really cool stuff. And when people ask me, I can't really explain what I'm doing. It's like so much, scientific stuff. But yeah, I try to like break it down, stuff like that. So yeah, coming back to your question, that the Master of Science was really the 2 years that helped me to stay in this track. Otherwise, like being a data science physician or a physician scientist would have been just a dream for me. I would have never done that. But yeah, and I hope to like carry on. I'm not sure like what exactly I'm leading on to. It's almost like I've narrowed down from 100 different ideas to 5 ideas at what I want to do in life, but I still want to have to like go to that one idea and then take that path forward. It's almost like coming down to the part of the funnel, which is not yet that part, but it's still there. It's not at least the rim of the funnel.
Absolutely. Well, who says you have like a certain time limit to decide? But it's
Yeah.
interesting. So you and I must have just missed each other because like I was doing the MPH and I graduated in 2021. So my whole year was, during the pandemic. But the thing that's interesting, I know you said it's hard to explain some of the projects that you're doing at Brigham and Women's, but I am fascinated, maybe on a higher level, some of the areas that you're looking into. And I guess anything that's been memorable and anything that's been challenging for you.
Sure. Yeah. So the one of the projects, which is like the biggest project for me, is to link clinical trial data with real world data. So I was always curious about improving health equity, right? So, and as we know, in clinical trial, like we don't have pregnant patients, we don't have kids, we don't have patients who are very old, frail patients. And if you go back into literature, you will see that obesity is a big group of chunk of patients who are never included in a trial because they have a lot of comorbidities. And most of the pharma companies and big sponsors, they're looking for a faster trial completion rate so that the drug can come faster to the market. So it's a very biased population that they study on. And what that leads to is a very bad external generalizability of the results. So when the drug comes to the market, a lot of off-label drug usage happens. And when you give those drugs as a physician because you think that, like it's a good drug and let me give it to somebody who was not a part of the trial population, you see a lot of side effects, you see a lot of adverse events, you see not so much of effectiveness, and the cost effectiveness also comes down. So stuff like that. So what we are focusing right now in the project is how can we link the trial data with a claims or EHR or registry data, not from the same patient, but necessarily, but can we simulate patients like that who was in a trial and then capture those data from the real world and combine both. It's called RCT, RWD, or real world data linkage, and make a bigger cohort. So let's say if there are 30,000 patients in a trial, and if we get 1 million patients in real world, so we combine both the data set, we pool accordingly, depending on the weightage, and then we report a finding which has value from both, from a very well-controlled trial environment versus what is happening real world in clinic. They're very pragmatic. So yeah, so that's a very high level. And the challenge here is that, the statistics differ a lot, because in trial you have different set of biases. In real world, you have different set of biases. You have selection bias, you have survivorship bias, a lot of epi biases. In RCT, you don't have a lot of bias at baseline, but then afterwards you have a lot of bias if people drop out, if compliance is not good. So it's a mixture of biases, and right now the challenge is how to deal with those statistically, like to find out methods that will help us to minimize those bias and get more accurate, the confidence interval as narrow as possible, not a wide one, which is not good. So that is one project I'm involved in. And when I said that, we do cool stuff, I think that is very cool in a way, because as a physician, I was a part of a couple of trials back home. When I came here, I learned about epi, which is a real world, and then the opportunity to combine both. I think that's fascinating for me.
Yeah, no, I love that concept. I've never heard of it before. The idea of like linking those two sets from clinical trials as well as things from like the EHR. From your understanding, like what other like centers is this happening at? So Brigham and Women's, at Harvard Medical School, makes sense that sort of novel, innovative statistical techniques are happening there. But do you know like where else they might be happening, or how they might, I guess, take hold in other areas?
Sure. Yeah, we collaborate a lot with VA. So we have VAs from all across the country almost. Like we get the data set, and as I said, and we specifically target VA because the elderly population is kind of not included mostly. The veterans, they're not included. Elderlies, they're not included. So that's a population we're really interested in, because from our experience, we have seen that they are highly neglected, and that is a big chunk of population that contributes to inequity in healthcare. So the drugs, they don't act well in veterans or people of that characteristics in those data sets. So that is one collaboration we have. And in terms of like other academic centers, I think Vanderbilt does a lot of good work in RCT-RW linkage. Then there is a Mayo Clinic who is slowly entering into this space. So they have a lot of like startups even coming out of this this space of real world evidence in cancer, in which you have to wait a really, really long time for clinical outcome, unlike a cardiovascular event, which can happen in 1 year. So yeah, and for a fact, I also know that the NPC, the National Pharmaceutical Council, and bodies like that, and the ICER, which is in Boston, they are also really interested, because it helps them to really understand the cost effectiveness of drugs, and in a way also understand whether the drug pricing is rational or not. Which is like a big debate with the cell and gene therapy coming in. And I think where we are heading towards in the future is moving everything right now. What I discussed between RCT and RWD, these are all for small molecules. These are molecules like in diabetes, for hypertension. But I think in future, what will happen, this entire thing will shift to CGTs, or cell and gene therapy, in which we have to wait for a really long time for the outcome to happen. And that's where the real play becomes. Like in a trial, you can have couple of patients showing and you can have accelerated approval. But what happens when the patient actually takes it after 10 years, after 15 years? So those are the data points we really want for the continuation of the drug in the market at that price point. So stuff like that. And as I said, so it's even beyond academia. I know a lot of startups even like doing this, a lot of like, as I said, veteran affairs and the federal government, FDA is really interested in this. So NPCs, ICERs, they're also like, it's an ecosystem, and we also collaborate with like a lot of like data vendors who have the data sources. Like so it's in this era of data science, I think the data source becomes the richest resource that you can have, because it's all about that, where it's structured, how good the quality is, stuff like that. So I think it's an ecosystem, and you have academia and non-academic partners as well. And like scientists, like researchers like me who are just starting in this journey, it's a learning curve every day. So perhaps the scenario will change every year. There would be more people from outside, even like so. Right now, we as a department we are in talks with people from European countries because they have a very good data set, starting from birth till death, because it's a universal health coverage for them. So that is something that we also are looking forward, because the more longitudinal data becomes, you have more covariates to adjust for in a way in your model. So yeah, I mean, like, it's a long answer, but that is how the thing is. Like it's a lot of stakeholders in it, and it's a very upcoming field of this linkage between the trial data and real world evidence.
Yeah, no, I think that answer is very fascinating. There's so many different things like within that answer as well. But there are two that I wanted to follow up on, and just thinking, like I said, about our audience, drug pricing. And you mentioned whether or not something is cost effective or whether or not something can be rational drug pricing. Could you dive a little bit deeper into that for the audience that may not know a lot about some of the controversies related to that? I mean, people may be aware that, say, insulin may be overpriced significantly. But could you just comment more on all of that?
Sure. Yeah, I think this is a great area of passion for me, coming from a lower middle income country. Just to give you a context, is that in India, where I come from, I did most of my education, we have a cap. We have something called MRP, maximum retail price. So your price cannot go beyond that. And when I came here, I saw that there's not, that concept doesn't exist, even in supermarkets. So everybody prices according to their own. And that being said, like countries like us, we also free ride on the R&D that happens in the USA. So in some way, the companies have to recover their money back. And that's why I understand that drug prices are really, really high in the US as compared to any other country for that matter, for most of the categories. So that's one context. But I also feel that, for example, we have like Mark Cuban's cost plus coming up. So in a way, you can cut down cost. My personal opinion is the entire supply chain of from pharma to patient, if you take those stakeholders, there's so many components in between that kind of increases the price from my experience. There are a lot of rebates happening in between the PBMs managing, the negotiation power with the pharma. But ultimately, I think there are a lot of research which have shown that if somebody doesn't have an insurance, then the out-of-pocket payment would be actually lower than somebody having an insurance. So this is a very controversial topic. So you have an insurance thinking that your OOP would be lower. So that's why you pay per month some premium. But that is not the case, it seems, especially for the underutilizers. So that is another area of research where, as a division, I don't focus on that a lot, but as a division at Brigham, we do a lot of research on drug pricing, because that is something like, especially in the cell and gene therapy, like these are all one and done therapy. So it's also a last in class. So if you get a gene therapy, let's say for hypertension, then you're done, right? You will never get an hypertension, let's say. So all the sartans and ACE inhibitors, whatever you have in the market, they're gone. So you're actually eating up that marketplace. So that's a justification for a high price. But if you think about target population, if they're Medicare and Medicaid patients, so the government has to bear the weight for that. So do they have enough budget to even cover those prices if it comes to the market? So that's a thought, right? And I think everybody is thinking, like in Boston, like there are organizations like No Patient Left Behind, and they constantly talk about all this, like drug pricing, how to think about the patients, right? So I think oftentimes they forget about them. It becomes a lot about the profit. It becomes a lot about market size, things like that. But if you do like even a 15 patient interview, you will say almost 10 of the patients would be not happy with the price, not happy with the OPs. So we really need to ask ourselves, if the patients are not happy with what is being done in the lab and reaching to the market after 15 years, after so much of R&D, is it really worthwhile? And can we reduce some of the components in between, some of the PBMs? Can we reduce the middlemen, as they call it, and not only treat the disease, but also treat the disease in a cost-effective manner? And it's easy to say all this, but it's difficult to do, I understand. So, and that's a constant, I think, effort that all the farmers are making, even small biotechs. I understand that when they do their pricing model these days, they think about that, that if it's priced at that point, can the patient population that we're targeting, if it's a Medicaid population, will the state have enough budget to even afford that? If not, will the payer cover us, in the Part D or in Medicare Part D, let's say, for example. So things like that. I think it's a great, idea or a great topic to think about and to write about, to discuss, because the more we discuss, the better models will come up with. And I think something like a value-based care, which kind of disrupted the paying system, the payer system. We need something like that for the pricing system as well. There need to be some sort of innovation happening, be it AI generated or not, but some sort of different models definitely need to be there for that pharmacoequity thing, so that everybody can afford. Right now, for GLP-1 RA, the out of pocket is close to $10,000. So that's not affordable. It's only affordable if you have so much of money. But if you don't have, then does your obesity not demand, like your obesity still need the drug, right? And so it becomes a question of that, of pharmacoequity, that how much a drug pricing should have a role in your accessibility and hence in your quality of life. So yeah, I think as a division, we focus a lot on that division of pharmacoepi, and the second part is pharmacoeconomics. So we always try to combine both. Whenever we're thinking of real world evidence, we always try to find the ICER value, the incremental cost effectiveness ratio. That if we decrease your blood glucose by 1 gram per DL or in percentage of HbA1c, what's the cost that you're going to pay out of it, and whether that's any reasonable, whether you can afford it, stuff like that. So yeah, I think so that is what I meant by drug pricing, and it's a huge topic. It's a topic that have been a point of debate in the Senate as well, by a lot of senators from ages. But I think there needs to be some sort of reform in that in the coming years.
Yeah, thank you so much for that. I felt like there was also a lot packed in there as well, especially for the audience. Not everyone may necessarily think of some of the terms you mentioned, pharmacoequity or pharma economics, if I'm getting them correctly, and whether or not that's related to public health issues, but they very much are. So I thank you for all of that. Lots to unpack, but I wanted to switch gears to data quality, clarity, overall, like the power and peril of data in healthcare. And so I just wanted to literally leave it open to you with that kind of comment and see what your thoughts are.
Sure, yeah, and I think it's like a very open. It's like an open-ended book. You can write chapters after chapter on data in healthcare. So one thing is definitely we have the computing power these days. So even 50 years back, there were data. Like if you go back to India in a small village right now, people still write on paper. So those data we are not capturing, right? Like my father is a pediatrician and he still uses a writing pad and a pen. So he has no data literally. If I ask him, like, can you give me a mean data of the age of the patient, so visit your clinic, he can't. He can give a rough number, let's say, like, but he can't, right? So it's still there. But I think in the US and most of the developed countries, we are really fortunate that we have computing power. We have power to store data, all the clouds, and if you go to one of the basements of a big factory, you will see, I think, all the data stored. The boxes which has the data, like billions and millions of data. So I think we are really fortunate in that way. So because we have that, and we have so much of technology coming in, right? We have LLMs now. And so if you can ask a prompt in English and you are getting a code back, it's fascinating. So I think that's the thing. So we have a lot of source now from different parts of the world, and we know how to use them. We have those techniques like AI model, be it deep learning, machine learning, or even basic statistics. Like you need not always go into AI for everything. You can have regression model also. If you don't want so much of fascinated or deep science, you can still do a very plain and simple logistic model, linear model, as they call it in statistics, and still get some sort of prediction if that's what you're looking for. And then I think the thing is, right now, even in medical school, even people who are going to schools or people who are just hearing in media, everybody understands what's a prediction model now. So if something is getting predicted, you understand. So you're not only a producer, but people are also becoming good consumer of data science. So now they know what is a prediction model. What do you mean by it's 80% accurate? So when COVID came in, people started talking about sensitivity, specificity, which are the core things of any model in data science. So now people know what you mean by high sensitivity, high specificity, a positive predictive value, all those big terms again. So I think the awareness. So there are three aspects. One is the availability of data. The second is the technology that allows us to use the data, and the awareness that people have right now, be it in academia, be it in science, or even outside science. Like I have a nephew who is like really small right now, and he also understands what it means to use something. And he was asking me that what is the difference between machine learning and human learning. So I was trying to explain him that machine is just like a human. The only thing, a machine has access to millions of data. As a human, we have limited capacity in our brain. We only read 3 books. Machine can read 300 books in 1 second, or like that. So he was like, oh wow, that's great. And so I was trying to explain to him that machine learning is the best medical student, and that's why you can see that ChatGPT passing USMLE scores these days, and even board exams. So because it has so much of access to data, it has so much of real-time access, which as a human we won't have. It's not humanly possible to know so much at the same point of time, and we need time to think about a differential diagnosis, stuff like that. So I think that's kind of the framework to think about data in healthcare. And moving forward, I'm pretty sure like every day, like the way it's changing, I'm pretty sure there would be a GPT 4.5, GPT 5, or large language might be like beyond language model. I don't know, like you don't even need a language for those models. Right now it's large, you might have small, then beyond language, you don't need language. So yeah, so I don't know where it will end. I think like, I don't have enough expertise also in that space of computer science and what's happening. But as a producer to some extent, and a big consumer of data science, I'm really excited. And I feel like, somebody who is listening to this, thinking about what they want to do in future, I think this is a perfect time to learn more about anything in data science, be it healthcare, be it any other field in public health, and then try to think where they can fit in the best. Like for me, I think I fit in the best as a physician who can understand data science. But if somebody is a data scientist who want to understand a bit of bio, bit of medicine, that's also perfect, because we need a team. You can't be just all by yourself. So yeah, I think that's the reason why we talk about so much of data science in healthcare these days, and that's what got me interested in this field as well.
Yeah, absolutely. No, I love that conversation. Like especially to me, I think the most memorable thing that you said was talking about your father being a pediatrician in India, and basically like that data is not being captured, but that's nonetheless data versus the data that is captured, the availability, the technology, the awareness of it. As we're coming to a close, Dr. Ray, what other advice would you give to the audience as they're thinking about the intersection of healthcare, data science, and anything else that you're passionate about?
Sure, yeah. I think that's a great question, and there would be no definite advice, right? Like, so what has worked for me till now, I don't know whether it's worked, but what I follow is that, like I always want to contribute the best out of me. Like because I know that if I had been back in India, I would have just been a general practitioner or something, like, just treating patients in OPD. I believe that that is not what I wanted, and I can contribute much more than that. So that's why I came here, and I took this route, which is kind of unconventional. So I think the best advice to somebody would be to kind of understand where your passion is. It's difficult, and it takes a lot of time to understand. I'm still understanding where passion is. As I said, so everybody starts from the rim of the funnel, and then you have 100 different ideas, 100 different passion. Then every year or every month you kind of narrow down. You might have 100 to 75 to 50 to 10, and then probably you end up with 3. And then you're at the neck of the funnel, and then you take those 3 ideas, and probably it's almost like drug development. You start with 100 molecules, you have 1 molecule reaches the market. So I think it's thinking like that, and where you fit yourself in a value chain, and everybody has value in the chain. So whether you are a data scientist or a physician, or who is ultimately delivering to the patient, or whether you're a patient, because we need patients to understand how drugs are working. So thinking from that entire value chain perspective, understanding where you fit the best and where you add the most value, whether that's a physician scientist, just a physician, or even a pharma person who develops in R&D in labs, or whether something after the drug reaches the market as an epidemiologist. So, or as a public health person who zooms out and takes everything into consideration and builds a system so that the last mile delivery, the vaccines actually reaches the person. So everyone in that value chain has value, and you need to understand, I guess, where you add the most and where you will be most happy being in that value chain. So that's a good I think framework to think, and that has helped me to understand where I fit in. And that's a question which only like the person thinking about this can understand and answer. Nobody else can help them. They can obviously ask for advice, but or look around and do courses, understand their passion, but that's a very individual answer, and you have to understand where you want to see yourself in the next 5-10 years. Obviously, understanding that the world is changing so much that every year your dreams might change, but it's perfectly fine. And it's also perfectly fine to, to switch gears. If you're not happy as a physician, go back to data science. If you're not happy as a data scientist, go as an epidemiologist. If you're not, you be a public health person. You manage a team who does all that. So everything is fine as long as you're creating a good impact in the world. That's all I just wanted to end with this answer.
I absolutely love like your energy and your enthusiasm. And I mean, I'll just echo some of the things that you said. I feel like, Dr. Ray, you're talking about things where people can live their more authentic selves and not necessarily be confined to one path, as you mentioned, to be able to see themselves within that value chain. And there's so many different sectors and subsectors that you said people can find themselves in, and then using that funnel to be able to decide where exactly your passions are. So thank you so much. This has been a great interview. I really enjoyed it. I hope the audience has learned a lot. I know I have, and so many things I'm going to go and have discussions with some other people as well. But thank you so much. If the audience would like to connect with Dr. Ray, you can go to bcph.org and check out his bio there and connect with him. And stay tuned for more 40 Under 40 Public Health Catalyst Award podcasts. Thanks so much again, Dr. Ray.
Thank you, Candace.